Welcome to this presentation on patent ductus arteriosus, presented by Dr. Saeed Rahman Khan Rumi, a final part student in cardiology at NHFH and RE. Patent ductus arteriosus is a common extracardiac shunt where the vessel connecting the pulmonary arterial system and the aorta remains open after birth. PDA occurs in about 1 in 2,000 live births and is more common in female infants. It accounts for 10% to 12% of all congenital heart diseases in infants. Risk factors for PDA include maternal rubella infection, high-altitude birth, premature birth, female sex, and genetic factors. The incidence is higher in infants born before 28 weeks of gestation. The ductus arteriosus is a vital part of cardiovascular development, originating from the distal 6th left aortic arch. It typically narrows and inserts at the junction of the main and left pulmonary arteries. In fetal circulation, the ductus arteriosus allows oxygenated blood to bypass the fetal pulmonary circuit. It remains open due to low oxygen content and placental prostaglandin E2. At birth, increased blood oxygen content and decreased prostaglandin levels lead to the functional closure of the ductus arteriosus within 15 to 18 hours, and complete closure within 2 to 3 weeks. PDAs are classified by the degree of left to right shunting and the size of the duct. Categories range from silent to Eisenmenger, each with distinct characteristics. The Congenital classification system categorizes PDA based on its appearance on angiography, ranging from conical to elongated with multiple constrictions. In full-term infants and children, spontaneous closure of PDA is rare. Large shunts can lead to CHF, recurrent pneumonia, or pulmonary vascular disease if untreated. Now, let's explore the clinical manifestations of patent ductus arteriosus. A detailed maternal and perinatal history can provide clues to PDA, especially in cases of rubella exposure or premature birth with respiratory distress. Symptoms of PDA vary with the degree of shunting. Small PDAs are often asymptomatic, while larger ones can cause exercise intolerance, dyspnea, edema, and palpitations. Signs of PDA include tachycardia, tachypnea, bounding pulses, wide pulse pressure, and a hyperactive precordium. A systolic thrill may also be present. A continuous machinery murmur is a hallmark of PDA, best heard at the left infraclavicular area. An apical diastolic rumble may indicate a large shunt. The duration of the diastolic murmur reflects pulmonary artery pressures. Elevated pressures shorten the murmur, and right to left flow may not generate a systolic murmur. Next, we will discuss the investigations used to diagnose patent ductus arteriosus. An ECG may be normal with a small shunt. Larger shunts can show left ventricular hypertrophy, and pulmonary hypertension can cause right ventricular hypertrophy. Chest radiographs can be normal with small shunts. Larger shunts may show cardiomegaly and increased pulmonary vascular markings. Pulmonary vascular obstructive disease can normalize heart size but increase PA segment prominence. This chest X-ray of a 2-day-old infant shows the ductus bump, a characteristic finding in PDA. Echocardiography is a crucial tool in diagnosing PDA, with TTE showing a 42% sensitivity and 100% specificity. On a 2D echo, the left-sided chambers, LA and LV, appear dilated due to increased venous return from the pulmonary circulation, leading to left ventricular volume overload. The dilatation of the left atrium results in an LA to AU ratio exceeding 1.3. The parasternal long axis view reveals LA and left ventricular enlargement. Additionally, the parasternal short axis view with color flow mapping indicates reversed flow, confirming the presence of a patent ductus arteriosus. Continuous wave Doppler echocardiogram position through the PDA shows retrograde flow throughout the cardiac cycle. Pulse Doppler echocardiogram reveals increased diastolic flow in the branch pulmonary artery, further indicating PDA. Cardiac catheterization can trace the catheter's trajectory from PA to OW through the PDA, creating a distinctive hairpin appearance. Oximetry shows steps up of O2 saturation in PA compared to RA. Pressure studies reveal normal RV and PA pressure but elevated in large PDA. PVR is normal in infants and children but elevated in adults. LV graphy and aortography help in identifying associated conditions like VSD and COA. MRI and CT are valuable in defining the anatomy in patients with unusual PDA geometry and associated abnormalities of the aortic arch. Management of PDA involves various strategies, starting with medical interventions. Pharmacological closure of the duct is often the first-line therapy for premature infants, with indomethacin and ibuprofen being commonly used. Secondary measures include prophylaxis against E and treatment of HF. The ACC/AHA 2008 guidelines recommend closure of PDA in cases of left atrial and/or LV enlargement, PA, or endarteritis. Consultation with ACHD interventional cardiologists is advised before surgical closure, especially for calcified PDA. Since the early 1990s, transcatheter techniques have become the first-line therapy for most PDAs. Complications are rare, with embolization being the most common. Percutaneous coils are preferred for older children and adults with PDAs less than 3.5 mm in diameter. The Amplatzer ductal occluder, ADO, is a cone-shaped plug used for percutaneous closure of moderate to large PDAs. It stents the PDA, forcing blood to flow through the center, leading to clot formation and closure. The ADO offers high success rates and the ability to be redeployed if needed. Images of Amplatzer ADO I and ADO II devices, showcasing their design and size. Lateral angiogram images show coil occlusion of a PDA. The small PDA allows shunting from the descending aorta to the pulmonary artery, which is eliminated by the Amplatzer ductal occluder device. Surgical closure of PDA has evolved since the first successful repair in 1938. Current procedures include ligation and division through left posterolateral thoracotomy and video-assisted thoracoscopic surgery, VATS. The surgical mortality rate for PDA closure is less than 1%. Complications can include injury to the recurrent laryngeal nerve, left phrenic nerve, thoracic duct, and potential recanalization of the ductus. Common complications of PDA include congestive heart failure, infective endocarditis, and pulmonary hypertension. Differential diagnosis for PDA includes VSD with aortic insufficiency, aortopulmonary window, pulmonary atresia with systemic collateral vessels, innocent venous hump, and various arteriovenous communications. Pregnancy is generally well tolerated in women with silent or small PDAs. However, in women with significant PDA, pregnancy may exacerbate heart failure. Pregnancy is contraindicated in those with Eisenmenger syndrome due to high maternal and fetal mortality rates. Thank you for your attention.